Susan Scott is the Patient Safety Officer at the University of Missouri Healthcare System in Columbia, Missouri. She's been in healthcare for many years and has been a leader, a researcher. But as you're going to hear, I have followed second victim programs, or another phrase that's used often are care for the caregiver programs, and even had one where I came from at Illinois and thought we did a really good job around it. I then started hearing about University of Missouri and Susan's work and had the benefit of seeing it and seeing Susan present about 3-4 months ago on her program, and realized what she has done and what the University of Missouri has done is just really eons further than anybody out there today, and I really look at it as a best practice. And as Susan will share, it wasn't an easy journey. It took a lot of effort and time. It was truly team-based and involved a whole organization moving forward. And again, as you hear Susan talk for the next 45 minutes, I want you to think about what you're hearing her say, and can we as an organization, as well as you at your individual sites, put a program like this in place and execute it to the success that Susan and the University of Missouri has been able to do. And again, we'll have a little more breakout time to have those discussions, but I'm going to turn it over to Susan now and thank her for joining us today. Susan Scott.
Thank you, Dave.
Oh yeah, we've got that.
Dave and MedStar staff, thank you so much for this opportunity. I truly believe that awareness of the second victim phenomenon is probably our first intervention, and can actually be only interventions at many, many facilities if staff just knew what they were experiencing. But before I start, I'd just like to ask, how many of you have ever heard, before today's announcement of the meeting, ever really heard the term second victim before? Oh, that makes my heart warm. When I did my first presentation in 2008, I had one person out of 100. And at the end of the day, she came up and she said, the only reason I know is because I was one, and started crying and told me her story. And so since that one woman in 2008, I probably have talked to hundreds, if not thousands now, of clinicians who have experienced the second victim phenomenon firsthand. And I would guess that clinicians in the room probably have experienced it as well. So my goal today is to enlighten you on the topic of the second victim phenomenon, talk a little bit about what we've learned through our journey. Have you ever had one of those little projects where it's going to start out as a little PI team and be done in 6 months and you're on to your next project? Well, that started me in 2006, and so I'm still heavily invested, as you can tell, on this project. So just to tell a little bit, so I'm from the central part of Missouri. Yes, I didn't know if you knew that, but that's the correct pronunciation is Missouri instead of Missouri. A lot of people ask me to repeat where I'm from just so they could hear me say it again. But I'm from the very central part of Missouri in Columbia, right on I-70. We're equidistant between St. Louis and Kansas City. Our healthcare system, just to give you a little perspective, is a very small healthcare system, an academic healthcare system with about 7 hospitals, and we have about 6,500 staff. So compared to some of your facilities, this is a very small system. So what you could do is consider this as a pilot project for a bigger system, in a way. As a chronologically gifted nurse, but as a brand new patient safety officer in 2004, I learned right away that there was a lot to the art of doing a human investigation. And I'm talking to patient safety folks and risk managers and leaders that already know what I'm talking about. But my very, very first real investigation of a serious event was with a colleague who I had known for many, many years and admired, a neurosurgeon. And he had made a 2-millimeter error in one of his procedures that led to the fatal outcome of his patient. And so afterwards, we had an incredible discussion on what his insights were on the case. It was about 36 hours after the event, but he had had time to kind of mull it over, as we say, and think about what happened. And so he gave me this uncannily detailed description of the procedure that he had gone through, and what he's starting to share with his residents, and what he's learning, so that others would not have that 2-millimeter error in the future. And at the very end of our dialogue, I said, wow, that had to be tough. Are you doing okay? And that was the point where I felt totally inept as a patient safety officer. He started sobbing. So this gentleman that was I admired for many, many years, who is an icon in the world of neurosurgery, was reduced to tears and wasn't really sure if he really wanted to be a neurosurgeon anymore. And when I went to reach in my toolkit of support, I realized that it was pretty empty. I mean, I tried to be an empathic person, but empathy wasn't going to cut it on this case. And so I just sat and listened to him, and just, a quiet silence for a very long period of time. And by looking at nods, I'm guessing that many of you have been in that similar situation before. So I went to my leader, Dr. Les Hall, who is another admired clinician, and I said, boy, these are my findings, but my biggest finding is the impact that this case had on this gentleman was incredible. In fact, it was the biggest finding that I had in my whole investigation on that case. And Dr. Hall said, oh, well, that's what you call a second victim, Sue. You need to start looking it up and get used to it as a patient safety officer. So I looked it up, and there really wasn't a lot out there in the literature. I heard, it seemed like the more clinicians that I talked to, the more they were kind of almost repeating. I could close my eyes, and I could be talking to a scrub tech, or I could be talking to a nurse, or I could be talking to a doctor, and they would say these same visceral responses to me that anybody would say, male, female, seasoned, brand new grad. It didn't really matter. I've had 3 people now tell me they wanted to be a Walmart greeter because they couldn't mess that up. And many times when I share this slide, I've got others that say, I've heard the same thing. So it's amazing the intensity of these events. So Dr. Hall told me to look at what a second victim was. And the literature wasn't very deep. In the 80s and 90s, most of the literature on clinician responses to error were medical staff related and related to the litigation process itself, and not really to something that's happened acutely in the healthcare environment. So Dr. Albert Rue from Johns Hopkins, just right down the road, was the first gentleman that actually wrote about, and he actually coined the term second victim in 2000. And this is about a page and maybe a half editorial in the British Medical Journal that just described what his colleague had gone through and the intense pain and suffering that he had observed and was witnessing. So shortly after that, actually Tony's story happened about 3 months after my first story, but Tony lets me share this story. His name's been changed, but he desperately wants folks to understand what he went through. And so Tony's story started on a Friday night. It was late on a Friday afternoon, and Tony was asked, as an experienced nurse who was really, really good at moderate sedation procedures and just an overall good nurse, like anybody hypercritical about their care like myself would want Tony at my bedside. That's the kind of caliber Tony was. Tony was often sought for support by the clinicians. So he was working with the proceduralist, and really the patient needed really minor sedation during the whole procedure. And so Tony had kind of developed a relationship. The procedure was supposed to last right about an hour. And the patient was in his mid-40s, had lots of comorbidities, but needed this central line so that he could go home, have some treatments, and then go home. And so the procedure lasted a little bit longer than they thought. At about an hour and a half, they actually gave the patient the option of waiting until Monday, kind of regrouping and waiting. But that was his ticket to go home. He realized that if he could get this procedure done, get the first treatment done, then home was on the near horizon for him. So he said, please keep going. So about 2.5 hour mark, they were putting in the very last suture to secure the tubing, and the patient took a deep breath and went into a cardiac arrest. After about a 60-minute resuscitation attempt, the patient was pronounced dead. And so Tony and the proceduralist alone went to talk to the family about the patient's procedure and the patient's death. So you could imagine you had 2 distressed clinicians talking to a distressed family, and the topic of disclosure and just working with families in crisis is one thing. But from that perspective alone, we should have had a third, kind of a unbiased party assist them with their discussions, but we didn't. Late Friday night, the resources were limited. So Monday morning came, and I learned of this unexpected patient death, and I started my investigation. First, I tried to contact the proceduralist who was off that day. Then I thought, well, I know Tony works closer to evening shift hours, so I'm going to just kind of start my chart review. And We always have medical staff review and nursing review of these documents. So I initiated both of those reviews. And late afternoon, I finally got hold of Tony and was talking to him. And he was very, very similar to my neurosurgeon. He was giving me incredible details and hypothesizing what could have gone wrong. And in looking at his documentation, have you ever put out a policy with a document accompanying it, how it should be done? This is how it looked. I mean, vital signs meticulously documented, very neat. You could read exactly what was going on. Armchair quarterback really couldn't find anything that would show even a subtle sign of deterioration in this patient. So Tony did this, and so I should have learned. My lesson should be not to ask at the very end, wow, that had to be tough, how are you doing? Because I got almost the same response from Tony as I did from the neurosurgeon. Now I'm flipping my questions. I asked that first because we're trying to do humanistic investigations. So now we ask the clinician first how they're doing and giving them support, and then starting the investigation as a second piece to that. But I told Tony, I said, Tony, I don't know exactly what you're going through, but I've talked to people, and this is some of the things that I'm hearing. They don't sleep at night, they can't eat. And Tony had not slept in 72 hours. And he actually didn't know what was wrong with him. He really felt like he was on the edge of a psychiatric breakdown. And he said afterwards, if I would have known even the word second victim, I could have Googled it and looked it up and realized that what I'm going through isn't some very, very abnormal situation. So one of our first key lessons that we learned was normalizing the event by explaining what they're seeing and what they're going through. Really helps the clinician on the right path to recovery real quickly right after the event. As an aside, I got hold of the proceduralist the next day, and he called in sick because he had restless nights. He guessed he slept about 4 hours that weekend in total. So now whenever I have an unexpected absence after an event like this, my usual routine is to not invite people when they're off the property, when they're at home. But if they're unexpectedly absent after an unexpected event, that's almost my ticket to go ahead and call them. And that's been very, very helpful. So it felt like everybody I talked to could have been a second victim. It felt like everywhere I looked, there was a second victim in a way. And so Dr. Hall said, how can we quantify it? What can we do for a prevalence kind of study? So I was just getting ready to roll out, we use the ARC Patient Safety Culture Survey tool, and so I was just getting ready to roll out our very first one in 2007. And I added these two questions. Within the past year, did a patient safety event cause you to experience anxiety, depression, or wondering if you were able to continue to do your job? And if they said yes, then there was a second follow-up question, did you receive support from anyone within our healthcare system? Sadly, our first results in 2007 showed 1 in 7 clinicians, just under 1 in 7 clinicians, did have an event in the last 12 months. And only 30% got support from us. The other 70% had to get support on their own. So this was the ammunition that I took to the C-suite and said, put together a team, let's figure this out. And so this approach was really, truly a bottom-up and a top-down approach. Because we had a lot of people from the front lines. We had almost everybody on this team actually was a second victim at one time. In fact, I was sharing last night, our first 4 meetings was filled with tears and sobs and stories worse than the next. And I felt like I was in molasses because we weren't getting anywhere. But yet, those first 4 meetings were so meaningful to people, outsiders who were watching us. Like, we had a social science researcher, we had an EAP, the director of our EAP services, and then we had a nursing researcher. And all 3 of them realized that people were pretty much telling almost a similar story, and how could we pull it together? Oh, and I did forget, something a little bit unique that a lot of people asked me about. The project leads for this were myself and my risk manager that's in our facility. We partnered together because she's been working with second victims for probably about 20, 25 years now, and she's kind of figured out her own way to help support them. And so that was really helpful to have the leadership, have a dual leadership. So our improvement teams, for our innovations, we had really 3 main objectives that we wanted to fulfill, and we didn't realize how much time-consuming this would take to fulfill this. We realized that we were having human toll, and we wanted to figure out a way to minimize it. We wanted to be able to provide a safe zone, almost like our first 4 meetings. Many of these stories hadn't been shared in decades, some of them. And it felt so reassuring to these folks just to get it off their lips and in the confines of this protected space where they knew people weren't going to judge them as a weak nurse or a weak doctor, but just to hear their story. And then last, we had deployed our rapid response team for patients in 2006 system-wide. So we decided, why don't we deploy a rapid response team and provide emotional first aid for our clinicians. So we used the roadmap that we used to deploy and all the action items to deploy our rapid response team to try to emulate and develop a rapid response team for our clinicians. We realize, though, that everybody kind of has different needs, and how one realizes they get support is very different from how another person gets support. So we realized we needed to form a qualitative project. So we formed a qualitative research project where we wanted to interview 30 clinicians. We wanted to interview 10 nurses, 10 physicians, and 10 others. So respiratory therapists, social workers, pharmacists, those types of individuals who work in the healthcare system who can be harmed by errors. And we actually, before we had any results to look at, we had 2 huge, huge red flags. So whenever you plan a study like this, you need at least 4 times the number of people to approach before you can have your whole subset of the 30 subjects. We hit 44 and we had it. So people wanted to share their stories. They really wanted to get their information out. And the second red flag is I was just preparing to do my very last interview, and I had a phone call from another registered nurse who I had known for quite a while. And he said, I just had dinner last night with such and such. And I'm like, okay. And I knew that that was one of my participants, but I guaranteed anonymity. So I was a little bit unsure of how to handle it. And he said, he told me that he feels so renewed. It's been 3 years that he's been stifled. And he said after he did the interview with us, that night he had the best night's sleep, and he just felt like a load had been lifted. He goes, is there any way I can share my story? I need to feel that lifting off my shoulders. So 2 huge messages before we even started looking at the reams and reams of data that was transcribed. We had a nice split in the population of the 31 clinicians that we interviewed. We had about 58% nurses. You could see these aren't youngins that we interviewed. The most senior clinician was a nurse with 36 years of nursing experience. The youngest clinician was a new grad with 4 weeks since she got her diploma. And then the average time of the event was 4 weeks up to 44 months. And both of those spectrums on that range has gotten some criticism. 4 weeks is, boy, that's pretty fresh. And our first goal was to do no harm. We wanted to help people. We didn't want to make it worse or harm them worse. So what we found, though, is that it was so helpful for this young nurse just to share her story from a personal perspective. And we didn't ask things about the case. I mean, we asked a general kind of question about the case, de-identified. But 99% of our questions were, how did that affect you as a person, as a professional? And she said it was so nice just to be able to say, you know, I'm not sure I should be a nurse anymore. I love it, but I hate it. I really want to try it, but I'm scared. And not to be judged. And so that was an important lesson from this very young nurse. The 44-month nurse, we actually invited her to tell a different story. We thought she would tell us a different story, and she told us another story that was 44 months out. But it was impeccable details that she provided, including the name, the date. She gave the room location where her event occurred. She described in detail the scrubs that she went home to wash that sit in the back of her closet today, never to be worn, so she could remember that special patient that really impacted her so deeply. So we got a lot of rich information from her as well. What we found from our discussions with these clinicians is that there's some high-risk events, and we pretty much predicted that. We figured out that the pediatric cases, any kind of a medical error, would be hard for patients. These failure to rescue cases where there's these subtle declines in the conditions but not obvious physical changes in the patient until the armchair quarterback can go back and look and say, oh, look, we were going down here, we were going up here. But those kinds of cases. So we knew that those 3 would probably be hard for staff. But the very first one keeps getting reinforced almost on a daily basis to me. It's the patient that connects a staff member to a family, to their own family. And we're starting to see that more and more. And if you can start talking to the clinicians, I mean, you've got some people that have armor on. They go to work every day. And all of a sudden there's this one case that just kind of teases through that armor and goes straight to their heart and just renders them almost unable to perform. An example is we had a registered nurse in our emergency room, and I used to like the show ER with Dixie. You know, Dixie could go deliver a baby, and she could go do open heart surgery, and then she could go out and, you know, Dixie could do anything. So one of the second victims I'm still kind of working with is a Dixie. I mean, she's my go-to person. And one day they brought in a 10-month-old child that was in full arrest, suspected SIDS. So she was right there. She was cutting off the pajama bottoms, and she was performing fine. She kind of stumbled a little bit when she got to the left thigh and saw a star-shaped birthmark in the same spot as her 3-year-old son's birthmark. That stumbled her a little bit, but she was still able to perform. She said, "We need a name. We got to talk to this family. What's the name?" And the name was like Demarian. I mean, it wasn't like Sue or Sally. It was Demarian, and that was her child's name. And the next thing you know, she's totally rendered unfunctional. She's up against the wall, and she's just like watching it all go on in a blur. And she describes it as, "Boy, I don't know what just happened to me, because usually I'm right there." She goes, "Something hit me. Something slapped me." But she didn't even put 2 and 2 together. Same name, my child's the same name, birthmark, male. There was too many similarities to that. And when we start talking to clinicians, it's this connectivity with their own family that makes them vulnerable. So if you could talk to them about that. Sometimes it might be hard to tease out. You know, I worked with them last weekend. They did fine. They had visitors. Their little grandkids were so cute, red curly hair, reminded me exactly of my grandkids, on and on and on. I'm like, bingo. How old are your grandkids? 3 and 5. Okay. How old was his grandkids? Oh, 4 and 6. Pretty close. That could have been my husband laying in that bed. The other similarities are names. It's incredible how fate kind of intervenes with people. I'm working with a group from the Women's and Children's Hospital who had a young patient die of a pulmonary embolism in their ICU. And the next week, the ambulance comes in with a young woman with the same last name, and they're trying to admit to that same room. And the nurse is like, no, we can't. We need to put him in a different room. But not understanding what was the connection is sometimes not conscious right away. You have to kind of tease it out to people. So connecting with their own family members is really, really important. We realized the high-risk clinical areas. In fact, when we started our first pilot project, we named off, ICUs, ERs, ORs, no-brainers. We had named off the first 6, and that's how we started our first team. We didn't realize, we have some other vulnerable teams that are not geographically based, but are more portable, like the rapid response teams and the Code Blue teams. These are our Dixie McCalls from the ER that go all over the hospital to help. And interestingly enough, they're these clinicians that are so expert that they don't even realize how fast they're thinking when they get to the side of the bed and start helping the patient with interventions. I did a study for them, and they were all familiar with the term second victim because we're trying to get our frontline staff knowing about what a second victim is. And when you said, do you feel like you might be vulnerable as a second victim? Oh, no. Like 12% said, yeah, I am. So a majority said no. Are you worried about your colleague over here, Cynthia? Cynthia's on the rapid response team. Do you think she could be vulnerable to this type of a response? 86% said, oh yeah, I worry about Cynthia. I'm fine. So this is a group that's highly vulnerable. So we've added some of their key players to our support team so they could actively surveil real time to make sure that everybody's doing okay. All 31 of our clinicians in one way or another, and whenever you see red text, that's from the exact verbiage from the second victim that we interviewed. All of them said that they carried around 1 or 2 or 3, one of them had 5 special patients that they were second victims for, and they reflect on them periodically through the course of the year. We typed and transcribed and typed all of their responses. We started with an hour, and as emotionally exhilarating as this experience was for them, it actually averaged about an hour and a half. So we had about 4 reams of single-space typed paper with people's responses on what they thought the response was like, what people needed to do, what they would recommend. But we asked them, one question was, as a second victim, what do you desire for support from your healthcare industry? And so this is called a word cloud. And it's a free software product that you can get, and you can just take a word product and dump it in, and then it'll just show the words. The bigger the words, the more often it appears. And the response, and you can make it different colors, different shapes. But, you know, if you could just keep this maybe in your mind when you're working with that next clinician that's really suffering from their event, they want immediate support that's available. They just want some caring. You know, what we provide is not deep psychological counseling support. I'm far from a psychologist or a counselor. That's the last thing I want to do. But I'm a nurse that's walked the walk with some of them, and I understand what people with second victims have told me, so I can just share that and help normalize the experience with them. But if you just kind of keep that one picture in your mind, that'll take you far in helping with interventions. I'm going to go over this very, very quickly. I excluded this from my slide presentation and a couple presentations, but people said that they really wanted to know what the stages were. So on these 31 clinicians, we found that there were 6 stages of recovery, and they should be in your handouts. And what we found was that the people go through them at different paces. So the first 3 are unique in that they can go through them sequentially or at the same time. And what we call these 3 stages is impact realization. They're just starting to feel what's happened. So chaos and accident is the instant you realize, boy, something's tragically wrong here. I don't know what it is, but something's going on. And then we'll go through each one of these. And then the very end is really, stage 6 is really more of an outcome than a stage. But there's 3 types of ways that people can move on. They can drop out, they can survive, or they can thrive. So just real quickly, as you're supporting clinicians, it's important to let them know that they're going to go through a lot of different feelings. And they're going to feel different, maybe minute by minute, maybe hour by hour. And that's really important for them to understand that. So that's why I put these slides back into this discussion, is so that when you're working with people, you can say, you know, 1 minute you're going to be fine. It's almost like when I buried my dear mama, like last year, there was moments when I was crying uncontrollably and moments when I was laughing. And it's like, that just is counterintuitive to me. How can I laugh at a time like this? And that's what they're going through. And it's like, boy, I'm just like emotional basket case. And so it's important for them to know, to predict that, you know, you're going to go through different things. So in the chaos and accident response, and once again, this is just what some of them have said to us. That's almost like you're driving down I-70, or I-95, I guess, here, and you get sideswiped. And automatically, you kind of go into this routine. I know I need to call 911. I need to make sure that if we can move the vehicles off, we move the vehicles off. Is everybody okay? You've been all through this before, so you kind of know. You kind of go through with rote memory. The clinician does the same thing because they rehearse and practice and practice and practice. But somewhere along the line, it's like it hits you. Oh my gosh, we could have all been dead. And then that's when they stumble. And that's when the clinician also stumbles. Intrusive reflections is when the clinician self-isolates. And this is a real dangerous period. And you can see it all the time. You see it in TV shows all the time. There's City of Angels had a story not too long ago where a young intern was in a bad event and she ran to the stairwell and just sat in the stairwell and just thought about the case. That's very realistic, and that's called the intrusive reflections, where they start mulling over, what did I do wrong? And everything is intensified on the clinician themselves. They focus on, what did I do? What did I miss? What could I have done better? Restoring personal integrity, they don't want to be the weak link on their teams. So what they worry about is that, boy, they're not going to want to work with Sue anymore. She's had 3 codes this week alone. She's like a dark cloud. Who wants to work with her? And, you know, sometimes this humor is just made light. I mean, but the second victim, that's really harmful for them because then they're feeling like, oh, I'm the big loser on our team. Nobody wants me anymore. When we found these 6 stages, we pulled the groups back together as focus groups to try to validate that these were the stages that they had felt, to see if we had missed anything. And they didn't change anything except for the title of this stage, of stage 4. I initially had enduring the investigation, and they made me change it to the Inquisition. And I had to that kind of put me back a little bit because I really tried not to be, I try to be blame-free, I try to be systems-focused. I do very little with the person and looking at the personal types of things. But the second victims all described to me that when you're in that position, it is an inquisition. You're going down and you're talking to Myra, the risk manager, who's in a suit all day long, and you don't know who she is. But boy, she looks intense. you know. So the fear of the unknown was really hard for them. I mean, they knew that when something bad happened, people would call and get their story, and not to talk to anybody because medical legally, they could subpoena anybody you talk to. So there's a lot of fear of the unknown, fear of what to do. So what they do is they don't say anything to anybody. That's what we still have a lot of that in our system. And so we realized this, and they asked us to change it to the word Inquisition. So painfully, I changed it. But just keep in mind, I mean, I've got a very, very bubbly, friendly, young, cute, charming assistant that does a lot of my investigations. And she's the last person I would think of to label as doing the Inquisition. But in their minds, that's what she was doing. So just kind of keep that in mind. Obtaining emotional first aid is really fascinating. These folks know that they're not right, but they do what I call a lot of hinting and hoping. In fact, we found that only about 15% of clinicians will actually reach for our hotline and call. They'll hint and hope that others will help. So they might go up and say, "Hi, Cynthia," and hope that Cynthia's like, "Gosh, Sue's usually not like that at all. Like, what's wrong with you today?" Just a lifeline. That's all they're asking for. What's wrong with you today? What's going on with you? I talked to a clinician from a hospital here on the East Coast who has a friend that has gone to some of my training, and he said, "You need to call Sue." And he explained to me that he hinted and hoped to 4 of his best buddies. 4. Before the 5th one said, "What's going on? You're not yourself today." But he said he knew he needed help, but he couldn't go up and say, "Jerry, I'd like to talk." But he would just hint and hope that Jerry would say, "Want me to sit down?" So obtaining emotional first aid is very, very interesting. It's very difficult. And what they said is that they hoped that people would just start with a one line, like I ended my conversations. "Wow, that had to be tough. Are you doing okay?" They said that's all they wanted. They just wanted the lifeline so they could just start talking to somebody that they trusted. So the last stage, which is truly the outcome stage, is different ways that they could go. They could drop out, they could survive, or they could thrive. In dropping out, they frequently will choose a different profession. They might quit medicine altogether and become a bench researcher. I've had many, many people come up to me, drug salesmen, who had a job that they loved, but now they have a job. How sad is that? I had an OR nurse that had a case of a retained foreign body, and she was so devastated by that she was involved in that she quit, and so now she's teaching a scrub tech program. And with tears in her eyes, she said, "If I could have only known what I was going through and that it was a normal response and that I wasn't abnormal or having a crisis, a psychiatric crisis, I probably would still be in a job that I love, that I've given up now." So there's story after story after story like that. A true dropout is people like Kim Hyatt. Does anybody recognize the name Kim Hyatt? If I tell the story, you'll probably remember Kim. Kim has a story for all of us. So Kim was at Seattle Children's Hospital working and in ICU, was taking care of a primary baby, and had to do a hand calculation of electrolytes. Okay, hand calculation of electrolytes. She gave it to the baby. She went home. She laid down in bed, and she said, "Something's not right." She called the unit and said, recheck my math. Something's wrong. I did something wrong, and panicked. Remember that very first stage, realizing something bad's happened? And she said, "I think I've done something wrong." Sure enough, she gave 10 times the dose of electrolytes. So she self-reported. And this would be a great case study for us to learn how not to handle a case. So she was truly thrown out there, under the bus. She lost her job. She went through a state board inquisition. Inquisition probably is not strong enough for this case. And about 7 months after the event, she committed suicide. Very similar to the nurse in London. You're taking care of the patient, and you fall to this false lie, and you transfer a phone call. All she did was transfer the phone call. But she let down the patient and the country. And so I can only imagine what she was thinking. So the ultimate dropout is suicide. And I'm sadly starting to hear lots and lots of stories. Just heard about an Illinois podiatrist that had a case in his office, respiratory arrest during a minor procedure. Fumbled the code, the patient died. And at the casket, the wife said, "He's never been the same since that day." So these things really strike deep to these people. These are survivors, are the second kind of outcome you can have. They figure out how to cope, but it's almost like their performance is at this level. They have an event, it drops, and it's never quite back to where it was. So you may have said this to yourself, boy, Sue's just not the same since that event. There's something, there's a light, there's a spark out of her somehow. She's not the same. That's the clinicians that have the outcome of being survivors. And then you have the thrivers, like my Tony. Now after every single code he goes to, he goes up after the dust settles, he goes up to who calls the code and just says, wow, that's horrible. Are you doing okay? Are you okay with that? So he's taken a really bad event in his life, but he's thriving by trying to give some life back to others and preemptively just having a conversation with people. So that's what the thriving would look like. There's also something interesting called triggering or tripping. And so what we see is we see clinicians that start and they progress kind of nicely through this and different kinds of time periods. But all of a sudden, they kind of lose ground. They go back. And so I also try when I work with a clinician to tell them, don't be surprised if you don't experience some tripping or some triggering. I had a classic example with a nurse who had a fetal death who shouldered a lot of the responsibility on herself. And I said, no, don't be surprised if you don't trip or trigger, and this is what happens, and you might be back here, tachycardic with sweaty palms and feeling like your knees are going to give out at any second. And about 6 months later, she actually paged me on a Saturday morning, and she said, oh, you're right, I got to give you this example of tripping. But it helped her to predict it. So she's in a comfortable setting in her living room, surrounded by her kids, and they're watching cartoons. And up comes a baby food commercial, a little toddler about 18 months in the high chair, blonde, curly hair, and was the center of the commercial. In her mind, that's what that baby probably would look like. And then she starts getting tachycardic and crying, and then she's realizing, oh, wait a minute, I think I just tripped over my event. And she could rationalize it. She can normalize it in her mind. It's no different than trying to predict what your response is to strep throat. You're going to feel really bad. Your throat's going to hurt. You're not going to want to talk. You take some antibiotics. You rest, and by 36 hours, you're going to be okay. But you know those first couple of hours, it's like, oh, my voice is gone forever. I'm not going to be able to talk. It hurts to talk. What's going on? Do I have a tumor? I mean, we've been there. But if the second victim can know what to expect, it normalizes it so that when it does happen, it's not so catastrophic to them. So for those of you into conceptual models, what we've had before is an unexpected clinical event, and we have these deep psychosocial, physical responses that our clinicians are giving us. They're emitting it to us. And then somehow, miraculously, they recover in one of these three ways. They drop out, they survive, or they thrive. So what we wanted to do is we wanted to do a rapid response team of emotional support, and how could we package this all together? So we realized they actually want 5 things. They want to be appreciated, respected, valued, and understood. But most of all, they still want to be a part of the team. They don't want people to think, boy, she's so weak. She'll cry again if we have another code. We'll give her the healthy end of the room. They don't want to be considered weak, and they don't want to be perceived that way. In fact, a lot of them have told us things like, it's almost like having a catastrophic diagnosis of cancer. And you walk in the room, and people don't know what to say, so they don't say anything. So how was that weather today? Did you hear we're going to be 50 this weekend? Instead of, boy, I heard what happened to you. Are you doing okay? That lifeline. So we did another experiment with the whole healthcare system, nurses, doctors. We invited 4,000 people to help us tell us about their second victim experience through a survey. And we had about 1,000 respondents. And from that, we were able to build an infrastructure of support for those clinicians. So we've actually tiered it. We've got a 3-tier model. So the first tier is local support. And I think most of the support, in fact, we're finding 60% of our support for our colleagues can happen here at the local level if you give the managers, the captains of the ship, the right tools. Tier 2 is where we have our trained peer supporters. We do referrals now to patient safety and risk management. And I can tell you, we're getting some rich information from that front line. Incredible information from that front line that's giving us some insights into how unsafe we truly are. And then Tier 3, our healthcare system didn't have a little menu of support. So we had all these resources in an academic center, But we didn't really have, you could call this person for this or this person for this. In fact, as a NICU manager for 15 years, there were many times where I would say, Jerry, here's the EAP card. I'm sure they could help you. Go ahead and give them a call. And then hope that they did that instead of trying to link them together in any way. So what we did was we just did an inventory. Who's out there? So we found a clinical health psychologist who loves working with clinicians, who volunteered her time and still volunteers her time and gives 5 free sessions with each clinician that we refer to her. We found a social worker who's really, really good with individual crisis interventions that we never knew about. I always knew her as the NICU nurse or the NICU social worker. I never knew she'd love to do crisis intervention and tap into a skill and make her engaged in her own work even more. So we made a little inventory. So now we could do this rapid referral. Before, if I called EAP, it was probably about 3 days before I could get them in. Now I call EAP, I tell them I have a second victim, and they're on the phone with that person instantaneously, if not on site. So they don't have to find their office suite, wait 3 days, sleepless nights. They could start their intervention right away. And I bet that you all have resources that you don't even have any idea about in your facilities. So real quick, these different tiers. Tier 1, I think that if you could talk about what is a second victim. So take these slides and talk about what is a second victim to managers, to staff, do brown bag lunches. We do a lot of brown bag lunches and open up to staff, and you'd be surprised how many people come in on their own day, on their own time, to learn more about it. So we talk about second victim. We use it as a term that's okay to use so that people can understand it. We found that there's 5 real things that the clinicians want from their supervisors. So whenever we have a second victim we're alerted to, and I talk to their supervisor, I said, do these 5 things, and they've got it on the back of their badges now. So they want to connect with the staff. The second victims that we interviewed talked about that the manager was there for that time, and then after that didn't even mention it, just walked by them. And they were so hoping that they would say, how did it go at EAP? Or, how are you doing? Just that connectivity. They need to hear that they're still a trusted member of their staff, if they are. I mean, we've had some that we've had to support that got terminated because of their event. But they were still a human, and we supported them until they were terminated, and then we had to turn them over to EAP. But if they have trust in the staff member, that's one of the key messages that they need to hear. You could take care of my baby anytime. I would love to have you be my nurse. You could be my mother's nurse any day. That's what they need to hear. Give them the option of flex time off. You'd be surprised. Many, vast majority don't take it at all. But just knowing I'm in control. If I need to go home, I can. And not feel like I'm letting down my team. Let them know what the next steps are. Let them know, I picked on Jerry too much. Let them know that this is Crystal, the risk manager. Introduce them face to face. So now instead of having people come down aimlessly looking for where the risk manager's office is, it's common to have the manager side by side with them. Let me introduce you to Myra. And that takes away the fear of the unknown. It just makes it a little bit easier for the staff. And then check on them regularly. They said don't just that same day worry about them. Worry about them like the next couple of days, the next couple of weeks. Tier 2 is where we took peer supporters. And so we asked for nominations from managers in these high-risk areas for people who were natural supporters. At the University of Missouri, we have a nursing ladder series. So we have a lot of committee members who get a point for their nursing series. And then, I don't know if you have that here, but if they're on the committee, then they get a point, and then they get a bonus at the end of the year. So it was really hard recruiting our first team, because we really didn't want a warm body in that seat. We wanted somebody with special skill set. We wanted the managers to pick, in the middle of the night when something goes wrong, who is that person that's a maternal kind of agent for that clinician that they would go to, that's a natural confidant. We just didn't want a warm body. So that's how we got some individuals. We now have 100 clinicians trained, including 12 physicians that include a medical student, a resident, a fellow, our dean of the School of Medicine on down. So we've got a lot of medical staff representation. And we spend a day and we train them on what is a second victim. They practice talking about it. I think that Kathleen said it earlier, we're not really good about talking about bad things. In fact, for a long time we were behind a veil of secrecy where we were told not to talk to anybody about it. Many second victims go home and don't say anything to their families because they don't want them to be deposed, or they don't want to compromise a case, and they worry about HIPAA. But that doesn't mean to say that they can't go home and say, I had a really, really, really bad day today, and my patient died. What we're hearing from second victims is that they would go home and they would have sleepless nights and they would pick at their food and they were very distracted the whole time, and their spouses thought that it was a marital crisis. So we're hearing from second victims now that actually went through divorces because they just didn't want to talk to anybody about it. So we've made a permission slip now, a little brochure, and it's on our website if you want to Google it. It's a permission ticket to give to their spouses and say, I'm being supported today, and it tells them what they could do to help. So sometimes it's just connecting these little bitty dots. In Tier 3, we've connected the dots of those resources, and coming soon is going to be a holistic nurse who specializes in stress management and relaxation techniques. So we might just have somebody who's just so distressed by themselves that they can't calm down or unwind. And so we've got this young lady that's got her master's in holistic nursing who's going to help us out with aromatherapy and just relaxation techniques and just kind of guide them to help to recovery. So now we've got the conceptual model where we've actually introduced the interventional support with an intent to influence the outcomes to survive and thrive and have fewer dropouts. Based on these findings, we formed a team, and it's called the For You team. It looks like a misspelled word, but one of our steering team members came up with the word so that it's all one word, and the focus is on you. So you've cared for our patients, now let us care for you is our mantra. And so we try to tuck together all of our research findings. These are our 3 teams. I think probably one of the reasons that we're successful is, here's my Dr. Les Hall. He's in every one of them. He actually starts the day off with his own personal second victim story. So what I didn't tell you was, after I had a couple of interactions, I said, you are so smart. How did you even hear about second victims? And he had his back to me, and he kind of turned around with tears in the eyes, and he goes, I am one, Sue. And he shared his second victim story. So now for our training sessions, he starts out the day, and you could hear a pin drop, where he talks about his Christmas Eve story and how every year on Christmas Eve he reflects on this case still. So we have key leaders that are here and very supportive. The other key leader is Dr. Hal Williamson. He is also a second victim. He's our associate vice chancellor for health affairs, and he too is a second victim. And so he's real supportive of our team efforts, and he says, I don't want anybody to suffer like I did alone. So lessons we've learned, we deployed our first team on March 31st of 2009. I just couldn't do a April Fool's Day kind of thing. So I'm superstitious, I guess. So we did a March 31st deployment. It took us over 3 years to pull this information together and to deploy our first team. So a new concept that I've learned is R&D. So some of you might think that's research and development, but in my patient safety world, R&D is rob and deploy. So shame on us for taking over 3 years to help support colleagues that are in distress and leaving the profession, leaving our facility to find something that didn't hurt so bad. So lessons that we've learned in those 3.5 years is everybody's unique, so we need to have a plan for each one of them. Watch for isolation. That's a scary, scary time. Think in concentric circles. Sometimes the problem is so big, you have to think, who's my red zone, who's my yellow zone, who's my green zone, and then proceed accordingly with intervention. We had a young scrub nurse, scrub tech, a couple weeks ago that had a pain in her calf and couldn't stand to work all day and was brain dead by that night. So her OR team actually performed an organ harvest on her. So we had a lot of red, green, and yellow zones that we were trying to deal with by doing group debriefs. We've had 10 activations in calendar year 2012 for a colleague that has died unexpectedly within our system. We've had 1 already in 2013. So we're sadly getting very good at helping managers coordinate what we can do when we have a colleague die. Cast a big net. It's bigger than nursing and doctors, and I'll show you some of my data. And then try to build surveillance into your regular practices. So like our post Code Blue, everybody is so busy and so hectic on the floors, it almost has to be put into the practice. So as they're packaging the patient up to take to a higher level of care, We actually do our huddle right then. What went well? What can we do different? Any lessons learned we need to disseminate? The fourth question is everybody okay? Check, 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 check. That was odd. So it's just kind of a surveillance methodology we use. It takes about 3 minutes to actually do this huddle in a postcode event. So real quick data. So this is our Peer 2 support and Peer 3 support that we can quantify. We can't quantify it at the Tier 1 level because the managers are just everywhere, and they're supposed to be doing that all the time. So we've had 203 in 3 years. We've had 48 group briefings. That number's growing. And we're starting to see leadership mentoring where they say, what can I do? I want to be the main supporter, which is wonderful. I would love for that pyramid to collapse to two tiers, local and professional. We really don't need to have a response team. So for a total of 639, and I'm just taking a peek at my 3.5 numbers, and I'm over 900 now. So we've had a lot of clinicians that we've supported. I really thought medical errors would top the list, and that's why I had general counsel so intimately involved in my planning. Only 16% of those 639 actually represent medical errors. 55% are unexpected patient outcomes that are happening on our floors. And 28% are the personal crisis. 2012 was kind of a bad year for University of Missouri. We had a helicopter crash. And fortunately, there was no fatalities, but there were career-ending injuries. And colleagues that maybe one nurse trade shifts that should have been in the helicopter, and how guilty she feels. And it's amazing how this ripple effects, it's like dropping a pebble in a pond. It really can impact people. We weren't really surprised. 60% were to nurses. 24% were to doctors. I was surprised about that. And I think that probably brings to mind that we have so many supporters on our medical staff. But the others are really important too. Like the plant engineering guy that helped lock the elevator when we went from the 7th floor to the 3rd floor for a child organ harvest, and the parents said goodbye in the elevator shaft. So my house manager's red zones were PI first, OR second, and as she was ending her shift, she thought, I haven't seen Harold. I wonder where he is. She went down to plant engineering and opened the door, and all she could hear was sobbing. He had a 6-year-old child at home too and wasn't going to come back the next day. So it's amazing. We have a lot of spokes that keep our wheels churning in our healthcare system that are not nurses and doctors that need to be considered as well. So about 15% required Tier 3 support. That's actually kind of slowing down a little bit. At first we were referring everybody because we didn't want to hurt anybody and we wanted to do it right, and now we're starting to get better at it. You could see where the people went. They liked having several options. They didn't really want a one-size-fit-all. They said, I wouldn't mind talking to a clergy, and I would like to help talk to a health psychologist. And so options is really good for them. This is just average times for groups. It's right about an hour. We try to save 90 minutes just so they can compose and get back together. We have 2 facilitators that are trained in group crisis intervention that can help facilitate the discussion. For every 6 individuals in the room, we have a lifeguard that's trained in the second victim support, and they're assigned specific tables to monitor during the group briefings. So there's lots of resources out there, and like I said, R&D is the best thing you could do right now. Robin Deploy. There's a group called Medically Induced Trauma Support Services that was started by a patient harmed by a medical error and her physician who was stifled and not allowed to talk to her. So MITS has a great toolkit. I'm trying to put all of my procedures and policies and everything out there just so you could take it and tweak it and make it your own. This is the MITS, the MITS website. There's a toolkit in the right upper corner. There's about 10 of us from the country and around the country that have support services for our clinicians, and we put all of our policies in it. So what you could do is take out all 10 policies and pick which works best for you, because it took us a long time to develop those infrastructures, and it's a long time you don't need to waste. And this is the front page of our For You team website. There is a share your story. And so if you have a colleague that wants to write what they're going through, what I found is healthcare providers are prolific writers. They love journaling and they love to write down what's going through. This is a portal that they can go in de-identified and just share, and it helps us learn more about what we're dealing with as a second victim. So in conclusion, caring for our own it's almost a basic lesson of civility and getting back to the basics on how to help our clinicians work through their really rough days. We have a lot of drama in our hallways every single day, and we get scarred to that. We don't even realize it. But sometimes that drama turns to trauma, and when that does, we need to be able to have an action plan in place to make sure that we take care of our own. So with that, I'll open it up for some questions.
Thanks, Susan. Questions for Susan? We'll take a couple of questions before we get into some small group work. Yes.
If a person serves as a member of a team and becomes privy to information that's divulged because the person is just opening up, if the person's a clergyman, if the person's a licensed psychologist or something, that's protected. If they are a nurse who happens to be good at this, what happens to that information? Is it deposed?
Very good point.
What's the status of that?
Okay. So did everybody hear the question? Okay. So we keep it very separate. So we have a main investigator and we have a chief supporter. So we have two different things. And so we talk to them initially as support intervention, and we'll tell them that we can get their concerns to the key people, but our main responsibility at that time that we're with them is for them. And what do they need? How are they feeling? What can we do to help support them? What do they need from our system? And so if they start talking about, boy, you know that syringe, that color was yellow last week, and I grabbed the yellow one and they changed it. No, that's important to know. You know what? I'm going to introduce you to the lead safety investigator for this case, and we'll make sure that she understands that. And so we have the supporters stay away, and so far, knock on wood, successfully, they've stayed away from intimate details of the case. If we have a real complex case, so we've had 2 out of those 639 that we've actually had to terminate because they were way outside scope of practice. So what we've done with that case is that we've had somebody so we have team leaders and then we have the staff. So we had one of the team leaders more experienced with taking care of staff support those 2 people. So we kind of knew that she was outside scope of practice, but we knew she was a second victim, both cases, and that we would have a special person support them instead of a colleague or a peer. That was too mucky for them.
But the confidence is shared. Are they introducible in a case?
So the documentation that we keep, we keep away from those conversations. If something's disclosed, we don't document it, we don't write it down, we don't do anything with it. Our outcomes data is very generic, like what kind of a person I worked with today, what was the case theme, how long did I spend with them, what was the outcome of the patient. We don't talk about the syringe was the wrong size and the wrong color and those kinds of things. So we don't keep any notes like that. And then it does help the clinician to talk about their own responses first, and then they compose themselves and can give actually a much better investigation discussion with the main investigator once they're a little bit more composed and know that the system's concerned about them and worried about them. Very good question. Thank you, because I didn't bring that up. We keep it very distinct.
Other questions? Got time for 1 or 2 more. Anybody?
Such a quiet group. I put them all to sleep.
No, here's the... Did you have one? Yeah.
I don't think you put us to sleep. It's just sort of like shock and awe, I guess I have a comment and a question. I wondered if you're familiar with the anthropologic data about Native American healing circles, and it's very much like that, listen and speak. And in my community, we have Warrior's Journey Home for the soldiers, and I looked at those commonalities in terms of the experience of isolation, and I still want to be viewed as strong and bold and able to do anything. And are you hearing about this penetrating our military hospitals? Because that's the story I'm hearing over and over again, that they can't talk to anyone.
And I've worked with a couple. I've worked with some of the Department of Defense down in, I guess it's Jacksonville or Gainesville, Florida, the southeastern quadrant of the Navy, and I worked some with the Army. And they're trying to do some of that work. But boy, think about it. I mean, they're fellow soldiers. I actually talked to a priest who has PTSD from helping the soldiers in Germany at the hospital where they're taking the soldiers. So, that has a whole new ramifications. I bet their prevalence is 90%, and I bet their support is probably 30%. So I'm working with different pockets of the military, but not with the Department of Defense or Heidi King. The theoretical, you ask about the Native Americans. So one of my theoretical frameworks to guide this work is Sacred Science of Caring, Jean Watson's work. And so she does a lot with the Native Americans. And so I'm kind of deep diving into that right now, but it's fascinating. And there's a lot of, you're right, there's lots of links to that.